الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين وعلى آله وصحبه أجمعين. Occupational Asthma by Professor Mahmoud Hani Sulaiman. Occupational asthma can occur in response to precipitations of animal, vegetable, bacteriological, or chemical origin. Some of more common occupations are animal lab workers, grain and flour workers, sawmill operatives and carpenters, biological detergents workers, electronics industry, paint sprayers, polyurethane workers, workers with epoxy resins or platinum salts, workers in pharmaceutical industry. So, more common occupations are animal lab workers. They are exposed to urinary proteins. Grain and flour workers exposed to mites and flour. Sawmill operatives and carpenters exposed to hardwoods. Workers of biological detergents exposed to inhalation of Bacillus subtilis proteolytic enzymes. Electronics industry exposed to colophony in solder flux. Paint and sprayers and polyurethane workers exposed to isocyanates. Workers with epoxy resins or platinum salts. Workers in pharmaceutical industry exposed to many drugs. This is the algorithm for clinical investigation of occupational asthma. First, compatible clinical history and exposure to possible causal agents. So the clinical history is very important, or occupational history. This will lead to skin and radioallergosorbent tests if possible. Then, assessment of bronchial responsiveness to pharmacologic agents. It is either normal or increased. If it is normal, subject either still at work, so there is no asthma, or subject no longer at work, so do lab challenges with the suspected occupational agent. If it is positive, this suspected agent, it is occupational asthma. If it is negative, consider return to work. When he will return to work, workplace or lab challenges with the suspected occupational agent, peak expiratory flow monitoring, or both. If it is positive, it is occupational asthma. If it is negative, it is non-occupational asthma. Again, return to assessment of bronchial responsiveness. If it is increased, subject who is no longer at work, do the same steps. If it is increased and subject still at work, go directly to workplace or lab challenges. If it is positive, it is occupational. If it is negative, it is non-occupational. This is the algorithm for clinical investigation of occupational asthma. These are major exposures, occupations, work tasks, and risk factors for occupational asthma. So, you use this table in taking careful occupational history to find the cause and try to prevent these materials in the environment or prevent the exposure of the worker to them in management of occupational asthma. These exposures in this table are diisocyanates, flour, detergent enzymes, wood dust, acid anhydrides, latex, reactive dyes, and aldehydes. In front of each of these materials, mention the occupations, work tasks, and risk factors. These are parts of occupational history. You must ask about them if you find some worker with asthma and you suspect it is due to his work. Continuing this table, you find these materials: colophony, green coffee, castor beans, animals, crab, laxatives, persulfate salts, antibiotics, cimetidine, enzymes, platinum salts, methylcrylates, latex, chlorine, acid or alkaline, gas, vapors, and aerosols. And again, in front of each of these materials found is work and the processes, and these must be prevented from exposure to them if they have occupational asthma. Careful occupational history is essential to find the cause. Continued occupational asthma cause from 2 to 15, average 10 of all asthma. Atopy is not a predisposing state except in a very few known allergenic disorders, e.g. in lab animal dander allergy. Although good occupational and medical history will lead to diagnosis, some cases are difficult to unravel. In these cases, resort to bronchial challenge testing, which should only be performed by trained staff, again, trained staff, and in hospital with full clinical backup. That's to say, full emergency services. Skin prick testing and serology for immunoglobulin E, IgE, levels are also of value. Treatment involves removal of sensitized worker from exposure. This may need change in job or move to job with less exposure, and non-specific treatment for asthmatic symptoms. Clinical picture of occupational asthma. Variable from airflow limitation and or bronchial hyperresponsiveness from work-related exposure. Obstructive type impairment with episodes of airflow obstruction in bronchial tubes. Symptoms due to obstruction are coughing, chest tightness, wheezing, and shortness of breath, although problems are often separated by symptom-free periods. Asthma is a chronic illness. This shows the FEV1, FVC, and FEV1 divided by FVC in a case of occupational asthma. Continued clinical picture of occupational asthma, either producing immediate reaction developed within minutes of exposure or late. In late type work-related cause may be missed. Some workers experience a combination of immediate and late effects, and others may suffer repeated episodes of asthmatic attacks. A suggested comparison for two types of occupational asthma due to agents of different molecular weight is given in table in next slide. Here in these graphs, it is given the immediate and late types of occupational asthma and the graph for dual case. The immediate reaction develops in 15 to 30 minutes and is short-lived. The late asthmatic reaction begins about 1 hour after antigen challenge, reaches maximum by 5 hours, and lasts about 24 hours. Risk factors for the development of occupational asthma: exposure characteristics, chemical characteristics, workplace characteristics, host characteristics. These are modifiable, and so try to prevent them in work environment and try to make the worker with occupational asthma do not expose to them. This is a long list for causes of allergic sensitization as determined by skin prick testing. In methods of diagnosis and investigations, skin prick test is present, as we said before. So this is a long list for what is found in this test. There are metals, bakery, animals, agriculture, chemicals and dyes, laxative, pharmaceutical, enzymes and spices, detergent, enzymes, textile worker, cellulose, fish products, insects, mold and fungi, plants, fruits and vegetables. Careful occupational history is essential to find the cause and try to prevent them in work environment. This is a longer list of the cause of allergic sensitization as determined by specific immunoglobulin E testing. So careful history is essential to find the cause and try to prevent them in work environment. Please print both tables and use them while you are taking the history of your patient. Management of occupational asthma goals are to control symptoms and prevent persistent disease. Control symptoms and prevent persistent disease. Achieved by complete avoidance of exposure to causative agent, to causative allergen. This is very important. By changing work practice, but this change practically requiring more major change of worker occupation. Workers almost reluctant to make changes sufficient to prevent further exposure because this will cause reduction in their salary. At present, further allergen exposure, even at a very low intensity, not advised. Further allergen exposure, even at a very low intensity, not advised. But if worker determined to continue, prevent as far as possible of exposure at high levels that incite symptoms or lead to changes in lung functions. These allergens, this exposure which incite symptoms or lead to change in lung functions must be avoided. Repeated serial measurements of peak flow during periods at and away from work are often helpful in this situation as is good pharmacological control of symptoms. This is a serial peak flow record of an employee with laboratory animal asthma. The shaded columns represent days at work. On each day, mean, maximum, and minimum peak flow measurements only are plotted. The figures in boxes at the upper of the graph are measurements of peak flow variability. Continued management of occupational asthma. Respiratory protective equipment is considered but is only effective if it is worn appropriately. So it needs training. And if it is removed, stored and maintained correctly. So the worker finds it clean and in good shape when he uses it again next day. There is some evidence that helmet type respirators can improve symptoms in some workers who continue to work where there may be further allergen exposure. Pharmacological treatment is as for non-occupational asthma but is generally ineffective with continuing allergen exposure. Generally ineffective with continuing allergen exposure. Conversely, little or no treatment may be needed once allergen exposure has ceased. There is only limited evidence that treatment with inhaled steroids improves prognosis in occupational asthma whether allergen exposure continues or not. Management of occupational asthma continued. This is for specialists. Acute asthma attacks require supplemental oxygen beta agonist corticosteroids, and if infection suspected, antibiotics. Hospitalization considered in severe cases because of potential for respiratory failure. Once diagnosis of occupational asthma made, primary intervention is to reduce or eliminate workers' exposure to offending agent. Substitution of offending agent with safer one. Improved local exhaust ventilation and enclosure of specific processes is helpful. With irritant-induced asthma, use of PPDs, personal protective devices, may lower exposures to levels that do not induce bronchospasm. Workers allowed to continue job must have regular follow-up visits, including monitoring of their lung function and non-specific airway responsiveness. For specialist, occupational asthma management continued. With sensitizer-induced asthma, however, workers should be removed from exposure to the sensitizing agent. Removed from exposure to the sensitizing agent. It may be necessary to completely remove worker from workplace because exposure to even minute quantities of the offending agent will lead to bronchospasm. If worker is required to leave workplace, e.g. baker with flavor-induced asthma, worker considered 100% disabled. 100% disabled on permanent basis for job that caused the illness and for other jobs with exposure to same causative agent. Workers should avoid exposure to other materials or processes that may exacerbate workers' asthma as irritating dust, mist, and vapors. Cessation of smoking and avoidance of exposure to environmental tobacco smoke are also essential. Cessation of smoking and avoidance of exposure to environmental tobacco smoke are also essential. This is very clear. Prevention of occupational asthma, efficient hygiene control in workplace, substitution with less allergenic materials, effective personal protective mask for worker in specific must tasks if exposure is anticipated. Identification of workers at risk, not an easy task. Determining a topic individual is of limited use, as up to 30% of population have atopic characters, and atopy is not necessarily a prognostic feature for occupational asthma. Health surveillance with pre- and post-shift ventilatory capacity measures, secondary prevention. This is for specialist types of respirator. First, air purifying respirators. First, non-powered disposable respirator. Then, respirator with filter or cartridge, full face piece respirator. Then, half face piece respirator. For specialists also, powered air purifying respirators. Please print and use. For specialists also, supplied air respirators, airline respirators, and self-contained breathing apparatus. Print and use. Key points in occupational asthma. Workplace exposure accounts for about 10% of cases of new or recurrent asthma in adulthood. Several hundred agents in workplace identified as capable of inducing occupational asthma. Most are airborne proteins or highly reactive chemicals. Occupational asthma usually has short latency and tends to afflict young employees who will need expert advice on career options. An accurate diagnosis is essential. In most cases, sufficiently accurate diagnosis achieved by combination of careful history, appropriate immunology, and comparison of serial measurements of lung function made at work and at home. Occupational asthma is potentially preventable. Prevention action should be focused on exposure control. وفي النهاية أقول الحمد لله و thank you for your good listening.